We are excited to present this research webinar on a recently completed project with NHTSA entitled Traffic Safety Culture and Impaired Driving. Our presenters today are Nicholas Ward, the Director of the Center for Health and Safety Culture, and Jay Otto, a Principal Scientist with the Center for Health and Safety Culture. Before we begin, we wanted to share a few notes about our technology. Next slide. So this webinar is being recorded. It will be available on our YouTube channel shortly after, maybe later today. To join the audio, either by phone or computer, in case you are dropped at any time, you can click on the three dots at the bottom to connect to audio. You can connect via your phone or through your computer system. Throughout the presentation, please use the chat box to send in any questions you may have. Please send those questions to both the panelists and the host. And at this time, I'd like to turn it over to Nick Ward.
Good afternoon and good morning, everybody. My name is Nick Ward. I'm the Director for the Center for Health and Safety Culture. And today I'll be talking about a research project we just completed, supported by NHTSA. Stacy was the liaison with that particular project. And it's all about understanding the shared culture around driving under the influence of cannabis. Just to start by way of background, our center is an interdisciplinary center that focuses on the role of the social and cultural factors in our communities that affect our behaviors related to safety and to health. And we conduct research, training, and give guidance to communities on how to look at their internal local culture and improve that culture in a way that gets the kinds of outcomes that they're looking for. The kinds of issues that we deal with in the center focus primarily on traffic safety, which is one of the topics for today, but we also look at substance misuse, domestic violence, and child well-being. But the focus of today's conversation was going to be on the research question we posed with NHTSA. Can we measure beliefs reliably that predict driving under the influence of behavior? And today I'll be talking about this particular project. I'll start with an overview of the study itself. We'll spend some time discussing the conclusions of the study, contemplate some next steps, and then open it up to the audience to see if we have any questions. As a starting point for this project, the work we do in the Center for Health and Safety Culture tries to understand the role of traffic safety culture in risky and protective road user behaviors. And ultimately, we're trying to understand how to create a traffic safety culture which supports Vision Zero. This is a quote that comes from AASHTO as part of their National Towards Zero Death strategy, noting that creating a positive traffic safety culture is fundamental to our nation moving toward a traffic system with no fatalities or serious injuries. In our center, we have a definition for what we mean by traffic safety culture, which is shown here on the left. Essentially, we see traffic safety culture as a shared system of beliefs. And we can think about how a shared system of beliefs not only influences groups of road users and what behaviors they may or may not do, but also how groups of stakeholders are influenced by the system of beliefs they share as well. On the right, we have a very simple model of what we mean by a system of beliefs. Basically, values and assumptions. Values, what we think is important. Assumptions are what we believe to be fundamental principles about how the system operates. Beliefs relate to particular behaviors. And these lead to our willingness and intention to engage in certain behaviors. So this model relates to deliberate behaviors, behaviors that we have a willingness or an intention to engage in. And the focus of traffic safety culture is to understand the system of beliefs that influences behavior. And we get these beliefs from several sources. One is our own individual experiences. So you can imagine this is a model for an individual person and the experiences they've had that leads to certain values, assumptions, and beliefs. But some of the beliefs that we hold also come from the groups that we identify with and belong to. So some of our beliefs come from the shared beliefs we have with the groups we belong to, what we call culture. And those shared beliefs come from shared experiences that we have with people in the groups we identify with, from socialization within those groups we belong to. And the whole idea of belonging to a group in part includes adopting some of the shared beliefs within that group that defines the group culture. So the culture of the groups we belong to influences the beliefs that we have, and those influence the behaviors we engage in. The focus of this study is trying to understand a particular form of impaired driving, driving under the influence of cannabis. And we know from data that there's evidence that there's more cases of drivers in fatal crashes with the presence of drugs. Specifically, cannabis seems to be increasing in terms of its presence in drivers involved in fatal crashes. So impaired driving is a significant traffic safety issue that we need to address if we have hopes of getting to our vision of zero serious injuries and traffic fatalities. And in this study, we're trying to understand the shared beliefs amongst cannabis users that may influence their decision to drive under the influence of cannabis. This was a survey study that tried to measure the relevant beliefs behind this behavior of driving under the influence of cannabis. As a starting point, we created a measure of driving under the influence of cannabis. And this is actually a scale, combination of 3 questions, which we combined to measure the behavior of driving under the influence of cannabis. One of the questions asked how often people do this behavior, driving after consuming cannabis within 2 hours. But we also asked questions about their subjective reporting of driving while being under the influence of marijuana and feeling high and still driving after using marijuana. So this is our primary measure of DUIC behavior: the frequency of engaging within 2 hours, driving while feeling under the influence, and specifically feeling high while driving. And you can see from these correlations, these 3 items are highly correlated. The more often someone's reporting driving within 2 hours, they're more likely to have also driven while feeling under the influence and feeling the high of the marijuana. So to develop the survey to measure which beliefs in the belief system influence its behavior, we began with this simple model, but we have a much more advanced model that integrates several psychological models of behavior to understand all the different components of culture, all the specific kinds of beliefs that can predict behavior. And this is an illustration of the more complex model. It starts off with the values, what we think is important, and the assumptions about the system we're operating in. We have beliefs about the outcomes of our behaviors. We have beliefs about what's normal. We have beliefs about our ability to control the situation and our own actions. And this leads to different components of the belief system, which ultimately influence our willingness and intention to engage in the behavior. So this was our framework for developing the survey, to ask questions about each component of this model to get a comprehensive picture of shared beliefs, that is culture, that relates to our particular behavior driving under the influence of cannabis. So the output of this model was reported driving under the influence of cannabis. We then created questions to measure all the other parts of the model. The one part we didn't include is called the prototypical image. That is our perception of the characteristics of people who always do or never do a behavior. To keep the size of the questionnaire manageable, we did not include questions for that particular component, but all the rest of the components were measured. And they were measured with multiple questions so that we could be sure to have reliable measures of each part of this model. So to begin with, we included measures of willingness and intention to engage in DUIC behavior. Willingness we define as an openness, should a situation arise, where people would engage in the behavior, and intention was more of a planned expectation to engage in a behavior, anticipating a future opportunity and planning to engage in that behavior. 2 related but different concepts. Note that the intention to do something, planning to do something, presumes you're also willing to do it, that you have an openness to it. Next, we measured the other components. Attitudes, we measured as subjective evaluations of DUIC behavior. For example, DUIC is harmful versus beneficial, and subjects would mark where on that dimension they felt DUIC behavior fell. We measured perceived norms about DUIC behavior. Two types of norms, a normative or descriptive norm, how often people think most people do it, and also an injunctive norm about expectations and approval for the behavior. In terms of how acceptable or unacceptable they felt most people important to them would view that behavior. And then lastly, we also measured perceived behavioral control, which is the perception of one's own agency in engaging or not engaging in a behavior. And we measure that in terms of exposure to situations where the person was able to avoid driving while under the influence of cannabis. So attitude, norms, and perceptions of control in terms of avoiding situations involving driving under the influence of cannabis. To explain how attitudes, norms, and perceived control influence links and intention, we then looked at specific beliefs that drive those other factors. So attitudes come from behavioral beliefs about the consequences of that action. So one example of a behavioral belief that leads to attitudes about driving under the influence of cannabis was this particular belief: if I drive after consuming marijuana, I will be better able to notice and respond to unexpected events. Now, these are beliefs that cannabis users have. They don't need to be true beliefs, but they're beliefs that cannabis users have. They're shared beliefs amongst people who identify as cannabis users. Then we have normative beliefs, where we asked about what specific people, not just people that are important, but specific individuals, specific groups of individuals, what behavior they normally do, and what their level of approval or disapproval is for driving under the influence of cannabis. And then for perceived control, we actually listed out different kinds of situations that might prompt or get in the way of driving under the influence of cannabis. So here's an example of just feeling bored and then using marijuana and driving afterwards as one of those situations that may increase the probability of driving under the influence of cannabis. And last, we looked at values and assumptions. Again, values are ideals to which we aspire. They are the basis of our goal-directed behaviors. They dictate sort of what we pay attention to is important in our environment. And we listed a number of different values that the research on values uses as being the sort of primary values that drive humans. And here's an example of one. How important to you is self-enhancement? Self-enhancement being defined as the values of achieving power, having a sense of self-achievement, enjoying oneself, and feeling stimulated. And then we listed a number of assumptions that people may have about cannabis and about the transportation system. So here's an example of an assumption about legalizing marijuana, where the assumption is that because it's legalized, it must be safe to drive. So that's sort of an overview of the framework we use to select questions to measure each part of this model. And we use several questions for each box so that we could make sure we're reliably measuring that concept. Next, I'll talk a bit about the method we used in this survey design. The fundamental part of this method is that we had a sample that completed our survey at time 1. And traditionally in this kind of research, people do a survey at time 1 and they're asked what they've done in the past. And then you use the survey at time 1 to retrospectively explain what people said they've done in the past. What we did instead, and the first time this has been done with driving under the influence of cannabis, was to instead have that same sample do another, repeat that particular survey in the future 3 months later at time 2. And in this situation, we're now looking prospectively. So we can use time 1 to predict what people said they did at time 2. And that is, in essence, what we're trying to do in this study is to see how well shared beliefs at time 1 predict DUIC behavior 3 months into the future. And then you can actually talk about the effect of beliefs now predicting future decisions to engage in risky behavior. And these are the results I'll focus on here today. So to talk first of all about the sample that we used a national panel provided by Qualtrics. It's a paid panel. It's a convenience sample, and it lets you identify, include certain categories of users based on your demographic targets. So first of all, to qualify to be in this sample, you had to live in the US between 18 to 70 years old, and to drive on a regular basis. Because we're talking about driving under the influence of cannabis, we wanted to have drivers involved. We did not choose a representative sample. Instead, we choose a quota of driver types to make sure we're getting a broad range of DUIC behavior and associated beliefs. So we made sure that half our sample was male and half was female. We made sure that we had a good range of cannabis use, 50% reporting that they never used cannabis, and 50% that did use cannabis, at least monthly. And we did deliberately include a portion of the sample that reported driving at least under the influence of cannabis at least once monthly. Our total sample was 525 participants who completed the survey at time 1 and then 3 months later at time 2. And looking at this table, you can see there was some dropout. 611 completed time 1, and then 525 completed both the surveys. But when you compare the two groups, you can see there's very little difference between them. So we're feeling there was no real bias evident from people dropping out and not completing the second survey. So let's now turn to the results we had with this study. Again, we're looking at the predictive validity of measuring shared beliefs at time 1 and predicting behavior at time 2. So what predicts driving under the influence of cannabis at time 2? Let's start looking at values, which is the first part of our model that we used to predict this behavior. First of all, we found that people who valued openness, i.e. being broad-minded, helpful, and self-directed, had more negative attitudes toward DUIC, had weaker perceptions that DUIC was typical or expected, and reported greater ability to avoid, greater control to avoid engaging in DUIC behavior. In contrast, people who valued self-enhancement, achieving power, having a sense of status and achievement, focusing on self-enjoyment and stimulation, they reported more positive attitudes toward DUIC, stronger perceptions that DUIC was typical or expected, and had a lower ability to control situations and avoid engaging in DUIC behavior. Moving now on to assumptions and how the assumptions people had about DUIC and the transportation system affected their behavior. We can look at this table here. And what I've done here is I've listed 3 of the most influential assumptions that we measured in this survey. The first one being that the legalization of marijuana implied that it is safe to drive under the influence of marijuana. The second one, impairment begins as soon as you start consuming marijuana. And thirdly, consuming marijuana after drinking reduces impairment from alcohol. Again, these assumptions, just like the beliefs, don't have to be true, but the ones that are held strongly by people who use this particular drug. So the first assumption that legalization meant it was safe to drive, that's clearly not true, but it's an assumption people have. And people who more strongly have that assumption have stronger attitudes or more positive attitudes toward DUIC, think it's more approved, think it's more common, and have less perceived control to avoid DUIC. Similarly, people who think and use marijuana as a way to reducing impairment from alcohol, combining the two drugs, also had more positive attitudes toward DUIC, more riskier perceptions of norms, thinking it was more acceptable, thinking it was more common, and less perceived control to avoid. In contrast, people who had the assumption that impairment begins as soon as you consume marijuana, that was a protective assumption. They had more negative attitudes. They thought it was less approved, less common, and they had better control over avoiding situations that might influence DUIC behavior. So the assumptions people held also affected other aspects of this particular model. Next, let's move on to attitudes and seeing how attitudes affected our results. And again, attitudes are influenced by beliefs about the consequences of engaging a behavior, in this case, DUIC. So one thing we noticed that the influence attitudes had was greater on willingness, openness to the behavior than on actual planning or intention. The belief that had the strongest influence on positive attitudes toward DUIC was the belief that if I drive after consuming marijuana, I will be better able to notice and respond to unexpected events. Notice that from the research in the literature, this is an incorrect belief. Generally speaking, marijuana reduces attention skills and reduces your ability to notice unexpected events. But people who believe this are more likely to have strong positive attitudes toward DUIC. And people with more positive attitudes toward DUIC are more willing to engage in that behavior and have stronger intentions, future planning to engage in that behavior too. Next, we can look at norms, what we think is expected and normal. Injunctive norms, what we think is acceptable and approved, influence willingness. Descriptive norms, what we think is common, influence both willingness and intention. And our perceptions of what our family and friends expect and what our family and friends do have the strongest influence on our perceived norms. People with stronger normative perceptions about DUIC were more willing to DUIC and had stronger intentions to DUIC in the future. Looking at perceived control now. Again, perceived control is our perceptions of our ability to avoid engaging in DUIC. In this case, people with a stronger perceived control to avoid DUIC were less willing to engage in DUIC behavior. Moving on now to willingness and intention, we've seen how the model predicts willingness and intention. How does willingness and intention then predict future DUIC behavior? Well, what we learned from the analysis is that DUIC is predominantly intentional. It's a planned behavior. It's less so something we just do spontaneously when the situation arises. It's more of an intentional planning type of behavior. And as predicted, people with higher DUIC intention, they were more likely to engage in future DUIC behavior. Defined again as driving within 2 hours more frequently, driving more often under the influence of cannabis, and driving more often while feeling high after consuming cannabis. So these shared beliefs influence willingness and intention to engage in DUIC behavior, and these beliefs predict future behavior, in this case, future behavior after consuming cannabis. So what can we say in terms of conclusions based on these analyses? The first is that we can reliably measure cultural beliefs that are relevant to the prediction of DUIC behavior. Our survey was successful in reliably measuring each of those components of culture, and our analysis showed that various forms of belief do reliably predict future DUIC behavior. In particular, our analysis showed that DUIC behavior is more often intentional, it's planned, it's a decision that is made. And if it's a decision that is made, we can think of strategies that can change that decision by changing the underlying beliefs that influence the decision-making process. And the particular analysis we did of the components of the belief system, the components of traffic safety culture, suggests there are certain types of strategies that could be influential in changing DUIC behavior. The first kind of strategies would address the incorrect assumptions people have. For example, the misperception or the misinterpretation that decriminalization of cannabis means it's safe to drive after using cannabis. How can we create strategies to correct that misperception? And how can we in the future discuss and present the outcomes of decriminalizing cannabis in a way that doesn't lead to that mistaken assumption? Also, the assumption that using cannabis can reduce the intoxication of using alcohol. How do we create strategies that correct that misperception too? Secondly, how can strategies be developed that dispel the false beliefs cannabis users have about the effects of attention on their driving ability? We saw that one of the strongest beliefs that influenced positive attitudes toward DUIC was the belief that people are better able to pay attention and notice unexpected hazards while driving. The basic research shows that that is false. How do we communicate that and resolve that mistaken belief? Third strategy type that might be helpful is to look at the role of norms, what people think is expected and approved and what they think people typically do, especially amongst family and friends, where family and friends have norms, expectations, and behaviors that contradict DUIC. How do we actually emphasize those norms to demonstrate that DUIC is not approved and it's not typical? And finally, recognizing that perceived control, ability to avoid situations that may influence DUIC, how do we educate and provide ways to avoid DUIC situations? So those are a few examples of types of strategies that the analysis from this survey suggests might be fruitful to explore in the future. So what are some of the next steps that this kind of research suggests might be beneficial to explore in the future? The first is how we may refine this type of survey. All the types of measures of beliefs we use were highly reliable. The measure of perceived control was reliable, but it was the least reliable of all the measures. So the question for us is, how can we review how we're measuring perceived control and see if we can develop an even more reliable scale for that component of culture? Having a tool such as this, which does reliably measure beliefs around cannabis and driving under the influence of cannabis, lets us explore other research questions. For example, how does decriminalizing cannabis in a state change traffic safety culture in general, but traffic safety culture specifically to driving under the influence of cannabis? And as I mentioned before, talking about strategies, the results of this analysis suggest certain categories of strategies that we could start to develop and test to see how effective they are in changing beliefs that are critically related to DUIC behavior. And with that, I will pause and see if we have any questions from the audience. Kelly, if you could let me know if any pop up in the chat window.
Will do, Nick. I'm not seeing any at this time.
Very good. Well, I thank you all for attending today. The results of this study will be published in the new year in a journal, and we'll be announcing that through our center website. If you do have any further questions for us about this research or any other activities at our center, please reach out to us at our contact email or give us a call. The website contains a number of other research projects that we're involved in that might interest you as well around traffic safety and the other public health issues that we're involved in. All
All
right.
right. Well, thank you, everyone.